Good morning. Thank you for joining us. I know most of you probably wish you were watching College Game Day. We were just talking about that. But this is a much more fascinating topic, nerve pain. You can record College Game Day. Let's watch this, but you can record this too. I'm Meredith Warner, orthopedic surgeon in Baton Rouge, and this is one of my favorite topics because honestly, this is why people come see me day in and day out, is really for pain. Pain is, of course, a subjective symptom that usually is just a sign of some underlying disorder. So we never really treat pain per se. We always treat what we think is causing the pain. The only time you treat the symptom of pain is when you completely obliterate it and mask it with like narcotics, which we now know is a terrible way to approach this. So I'm going to tell you what is a nerve, how does nerve work, and how does a nerve make pain, and then why certain things work to treat pain or not treat pain. All right. Oh, yeah, and if you could share the talk to your friends and whatnot, it'll be available afterwards too as a webinar, and we will have a giveaway at the end. But this is an important topic, I think, and I think the more you understand about why you hurt, the more you can sort of be empowered to control your own pain. All right, next slide, please. All right, next slide. Okay, I already said who I was. I'm Dr. Meredith Warner. All right, this is services we offer at my clinic. Everything I do is to try to empower people to get better themselves and give them tools so that they hopefully don't have similar problems in the future. Big believer in physical medicine, things like physical therapy, yoga, infrared heat, sauna, cold exposure, that kind of stuff. Natural herbal supplements, I think, are far more effective and safer than most of the synthetic drugs on the market. We try to avoid those. Certainly, I'm no fan of narcotics. They have their role for short-term acute pain after surgery, but really we try to avoid it otherwise. And then just basically getting people physiologically improved enough where they just don't have pain. All right, so let's talk about nerve pain. So what does it feel like? So you may wonder, what is she talking about? What is nerve pain? Basically, it ranges from like numbness and tingling, which is technically not pain per se, but that's one of the hallmarks of nerve dysfunction, to burning, or sort of a feeling of like hot water. Burning is a common word that denotes nerve pain. Electric is another word. Basically, it's pain that's evoked from the nerve itself, and it's not in response to a general stimulus, if that makes sense. We're going to get more into that in detail in a bit here. Some people are extremely sensitive to cold, extremely sensitive to heat. Just wiping the skin like this would hurt. And then the pain is sometimes accompanied by other problems like abnormal sweating and just the skin not working correctly, nerves not functioning properly. But basically think of it as like hot, burning, electrical kind of pain. Like sciatica, probably somebody out there has had sciatica or knows someone that's had it. It's that type of pain. So the words I hear often, really you could almost say, what is that person talking about? That makes no sense. But once you understand nerve pain, it all makes sense. My foot feels like a balloon. I hear that a lot. I feel like a sock is stuck in my shoe all the time. Burning hot. I feel like somebody's poured warm water on me. I cannot wait to take my shoes off at the end of the day. Once I take my shoes off, I feel much better. My hands are killing me in the morning. They're burning and I can't even use them. I'm dropping things. I have muscle cramps, restless leg syndrome. All these things, when I hear that, I start thinking ding, 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 nerve, this is a picture of a nerve. So something's going on that's irritating the nerve itself, as opposed to, say, a broken bone or, like a true cut through muscle or something. Something's making the nerve not act right, as opposed to a true injury, okay? So what causes it? So pain is a subjective thing. So pain is just a perception that your brain creates, and we're going to talk about how that works. Usually pain is protective. It keeps us from sticking our hands in fire, right? Or boiling water, and making sure that we jump out of the way of a moving car. So pain serves a very, very important function for us to survive, and it's evolutionarily conserved across species. So most species can feel pain, and they feel pain in certain instances, usually when it's something that's threatening to them. However, pain can occur without injury. It can happen for no apparent reason. You could have chronic pain for no apparent reason when there's no ongoing injury whatsoever. That is a much more complex thing that has to do with the circuitry between the brain and the body, and a ton of variables go into that. Pain that starts from the nerve itself is what we traditionally think of as neuropathic pain. Or neuropathy. So if it's ectopic firing, meaning like random firing of electricity from a nerve without a stimulus, without an injury, without a reason to have that, like without a cancer tumor producing inflammation all the time or crushing a nerve, then that's called neuropathic pain. And then we try to figure out what is making the nerve so dysfunctional. And there's a number of things. Oxidative stress and chronic inflammation of the current American lifestyle, probably one of the primary reasons people feel bad all the time. I mean, the diet in America, 80% ultra processed effectively, with terrible sleep patterns, pollution in the air, pollution in the water. Obviously, it's just a setup for failure, and we're all going to be in pain. So that's the first thing we can do to control it. We're going to talk about that. But poor diet, prolonged exposure to chronic low-grade inflammation, all of this leads to nerve pain. And then sometimes things like chemotherapy, different drugs for different medicines, different diseases can cause nerve pain. So what is a nerve? A nerve is basically it's like a slimy tube. It's white, it's kind of shiny. They're found throughout the body, up and down, crossways, diagonal, and they basically connect the brain and the spinal cord to everything else, okay? This picture on the bottom is the perineal nerve. That's on the outside part of your knee, and that's a nerve I actually release a fair amount surgically for entrapment or put peripheral nerve stimulators in. That is the pain people feel if that nerve there is entrapped or compressed or irritated or ectopically firing. People will feel pain down the side of the leg and top of the foot. Remarkably similar to what a lot of people complain about with sciatica. But that shows you a live picture of the nerve, and then this is a microscopic cartoon of the nerve. It's basically a bunch of threaded bundles, almost like tendons and ligaments. This is sort of how the body likes to organize things, spiral some bundles up. And they're all separated by different layers of connective tissue, and they have, vessels feeding them oxygen and whatnot. But that is what a nerve is. It effectively just carries electricity. It's like the power cord, working the computer right now. It's going to carry electricity one way and the other. And that electricity will signal certain neurotransmitters or proteins that signal different functions in the body and brain. All right, another definition of nerve is a person's steadiness or courage and how you brace oneself to face a demanding situation. And I think the two go hand in hand, because if you have nerve, then you can handle pain. You know what I mean? I don't want to make that sound too silly, but the reason the word nerve means steeling yourself and going forward, and the same derivation of the word nerve is used for nerves. There's a reason, because there's a strong connection between the brain, the body, and how you front face the world and how you handle stimulus coming in. And this has to do with mindset, which we will talk about later. We have a quick audio check. Just make sure can everybody hear me? Can somebody give feedback if you're hearing me? Somebody out there was having an issue hearing. So, anyone? My phone? I don't know. Okay, let's move on. Okay, so this is really important and really cool if you think about it, that really a nerve, the only reason you even feel pain is because of an electrical circuit, okay? Everything is driven by electricity, by what are called ions. These are molecules that either have a positive charge, a cation, or a negative charge, an anion. And the fundamental minerals that you think about, calcium, sodium, potassium, chlorine, all of these are massively important in our day-to-day life, and they're the only reason I'm sitting here talking to you, is because of these tiny little charged molecules that are running up and down in my body right now, firing, not firing, pumping in, pumping out, and sending signals and making my brain work and my mouth and voice come out. You can understand it, all because of these ions. Specifically sodium and potassium, and then calcium at the end of the nerves, and we're going to talk about that. The function of the electrical circuit, the actual spike in activity, is called an action potential. And then there are things called gap junctions on nerves, insulated nerves that are surrounded by this fatty layer called myelin. just like electrical cables have insulation, right? To protect them and to make them work better. Copper cables are insulated a lot of times. Myelin insulates our longer nerves, and then between the bits of myelin, there will be a gap, and this makes the nerve function more efficiently, a gap junction. We're going to talk about that. And all of this works because in that sheath, and then on the cell membranes, which we've talked about how important cell membrane function is before, in the cell membranes, there are a series of pores and channels and pumps that either let the ions in and out, stop them, let them leak in, let them come in a massive flow, induce an action potential or whatnot. But basically, the human body is a very controlled, coordinated system of ion movement. And that is all pain is at the end of the day. We can take a question. Hey, Sandy, we have a question from Sandy.
Can you have nerve pain associated with hip osteoarthritis?
With hip? Okay, Sandy's question is, can you have nerve pain associated with hip osteoarthritis? The short answer is yes. The only reason your brain ever thinks that you have pain is because a signal is sent from a nerve. Arthritis is an inflammatory condition, and the talk we gave before on arthritis showed that the synovial fluid from people with osteoarthritis, particularly advanced stages, is heavily inflamed. And when you have inflammatory cytokines and proteins floating around nerve endings, that stimulates the nerves, causes an action potential, and gives you neuropathic pain. So you can have nerve-based pain from irritated nerve endings in the capsule and the ligaments and the tendons and the bone. Remember, cartilage has no nerves, so you never really feel pain from the cartilage itself. But yeah, osteoarthritis can induce nerve-based pain. It's technically not called neuropathy because it's not coming from the nerve in and of itself. The nerve is actually irritated by the inflammatory mediators. All right, that was a really long answer. Sorry. All right, next. So I put this here because I just find this over and over again when I'm reading and studying and doing research. I'm just fascinated how everything that we humans do that we think is so awesome and inventive, if you think about it and go look, it really just mirrors something that's already been done in nature. They're starting to see this with the ways cities map out and transits. It all looks like neural connections in the brain. And here on the top picture is a power system, a power grid. You've got the generating station, you've got your transmission lines, you've got a step-up pump, you've got a step-down transformer, and then it goes to each of the individual homes. Well, look at it. It looks just like the body system. You've got the source of an electrical signal, you've got the transmission lines, you've got the step-up transformers, which is when it hits the next cell body and starts again and again. And then it goes not to homes, but to the peripheral nerve endings that say, oh, hey, you want to point there, or oh, hey, your cheek itches. All of this is the same thing. It's electrical signals start somewhere, and there's passed in a controlled fashion to go somewhere specific. So the basic circuit in your body is this. You have a neuron, and it sends the signals through the axon, through the action potentials to what's called a synapse. A synapse is just a connection between nerve A and nerve B. And so the synapse will actually drop out neurotransmitters. Those are like little proteins. Those signal molecules cross that cleft and then stimulate an action potential in the next nerve through these processes called dendrites, which are like the transmission cables, goes to the center core of the nerve. Another action potential is signaled, passes down the axon, through those areas, those gap junctions with the insulation of the myelin, and then it goes to another synapse, to another dendrite, to another cell body. So that's your basic circuit. So you can control things in your body by controlling the synapse, the proteins that are released or not released at the synapse, the reuptake of proteins there, the recycling of them, and then also how the action potential is propagated from the dendrites to nucleus. The nucleus obviously is filled with a bunch of genes that can turn on or off and then change how certain signals happen. And then of course, how your axon is functioning will also change the transmission of signals. But this is your basic circuit. This is going on all the time in your body, throughout your body, with or without your conscious control. Okay. All right, and this all happens because of the cell membrane. Y'all know I'm a huge fan of healthy cell membranes, big fan of omega-3, things like that. But in the nerve cell, it's especially important. You have to have a solid cell membrane that works perfectly because everything hinges on what's called a membrane potential, which is a charge gradient. So on one side you have positive, one side you have negative. Nature does not like uneven things. That's why a vacuum will always suck in air or water if it can. It likes things to be balanced. So if there's too many positive ions on one side, it's going to try to osmotically push them to the other side. If there's too many particles on one side, it'll push it to the other side. So you want this constant balance. The way that the nerve works is it keeps positive outside, and then the action potential lets the positive ions drop into the cell, changes the membrane charge in the cell from a net negative to a net positive, and that is the voltage signal that tells the nerve, pass this signal on, go to the brain, tell the brain X, Y, and Z. So the charges normally flow from positive to negative, okay, and also from a high concentration to a low concentration. This is controlled by what's called a semi-permeable membrane. So this membrane is not just like a piece of cloth where if you had salt water over here and fresh water with a piece of cotton, it would osmotically equilibrate over time. The membrane between controls it and only lets through the ions or cations or anions that it wants. And that's through either the channels or pumps. So at rest, when you don't have an action potential, when the nerve is not firing, like let's say the nerve to my big toe right now, you're going to have it permeable to some potassium and some chlorine, but then at rest, it's impermeable to sodium. So it won't let sodium through. Sodium has been built up to a higher amount outside, so it's net positive outside. And then as soon as you get that signal, it's going to drop in the sodium into the cell. The potential inside the cell is going to go from negative to positive, and then you get a signal. So just remember, it's all hinges on this membrane, and the membrane keeping negative inside, positive outside until there's an impulse from an action potential and the nerve needs to work. So what regulates that permeability? Well, the charge does over time. Also certain proteins, genetic things, different genes being turned on and off. But effectively, it's all controlled by the charge gradient, which is controlled by the voltage-gated channels, the sodium-potassium pump, and then there's some smaller channels that open or close based on mechanical things, or they might sense that the gradient is a little bit too negative on one side and too positive on the other side, and it'll let like potassium leak through a tiny pore that's really only big enough for one potassium molecule, if you could imagine. The voltage-gated channels, remember that term? That's everything to do with pain. And the voltage-gated channels is how we try to control pain and modulate it for patients. The voltage-gated channel would be the sodium channel that's generally closed until it gets a certain signal, which is a volt, right? A certain positive signal that tells it to open. And then the sodium floods in, and you get the same thing, just keeps propagating down the nerve. So all of this permeability is controlled by channels, pores, and pumps that are sitting in the membrane that are signaled either by a voltage, so positive or negative, or they're signaled by some mechanical thing, or what's called a neurotransmitter, which is a protein that will link on the receptor and cause it to open or close. So that was pretty complicated, but you could see here, so a closed channel and open channel. And that open channel will have a very selective filter. It will only let potassium, or it will only let through chloride, or it will only let through sodium. And generally, there's some potassium cells that are slightly leaky that let this certain resting membrane potential happen. Generally, it's negative 70 millivolts inside the cell. That's how it's supposed to be. And then there's a lot of positivity outside. If it starts to get too negative inside the cell, the system will let some negative anions leak out, or they'll conversely, if it's not negative enough, it'll let positive ions leak in. I may have said that backwards. But anyway, you get the point. Now, after the action potential happens, well, how do you get all the sodium back to the outside? Well, there's actually this ingenious pump system. So the sodium inside the cell binds to this pump on the cell membrane. And when you hear pump, you naturally think, well, that's active. Something is making this happen. And yes, it requires energy. So the pump actually uses ATP, the energy from an ATP molecule, to open and close. So it's open on the inside, sodium binds it, 3 sodiums, and then a phosphate group off of an ATP gives it energy, and it flips its conformation or shape. And then the sodium goes outside, and then 2 potassiums bind, and it drops it back in. So it just keeps doing this over and over again at a 3-to-2 ratio until you get that resting membrane potential that you need to make the nerve function properly. So it's a pretty ingenious system, and you may be wondering, why does it do that? And I'm about to tell you, but it's pretty cool. So again, everything hinges on the relative negative and positive between the inside and outside of the cell. Now, that is everything. That is all pain is. And so this is basically the pump gets you set up for the next action potential. Okay, so the signal, remember the basic circuit. We get another neuron, goes to the synapse. The synapse sends a protein, which triggers an action potential at the dendrite in the new nerve, and then so on and so forth. So the neurotransmitter at the synapse is key. That's a protein that attaches to a receptor that says, hey, let in an influx of sodium. Let's get this ball rolling. The pores open, the charge rushes in, goes from negative to positive, and then at a certain level of positivity, everything shuts down, doesn't let any more sodium in. The membrane potential equilibrates, the sodium switched for potassium, and it gets it all set up again. And I mean, this is happening like faster than you can blink an eye, obviously. This is like nanoseconds, which is amazing when you think about it. Okay, so this is the action potential. And I don't know if anybody out there remembers their high school chemistry or biochem, but this graph is the only reason that anything works. So you have that negative 70 millivolt resting membrane potential. If you get a certain amount of charge that comes in from another signal from another nerve, a certain volt, that volt will let in a certain charge. When it hits a certain level, that is the threshold. There's a threshold that's been met, and then you have an action potential. So once that threshold is met, the sodium channel's open, sodium pours in, you get this massive switch from negative to positive. Sorry. I'm getting so excited about this. And you get this peak action potential. So you go from negative 70 millivolts all the way to positive 30. So it's a 100 millivolt change. That happens almost instantaneously just because the pump, I mean, the channel open and let sodium come in. That's how quickly the body wants things evened out. It's peak action potential. Then you hit that number, and then these channels are voltage gated. Oh, that's too positive. We need to shut down. They shut down, no more sodium in, and then potassium crosses to get it even in polarization. Well, usually there's a little bit too much. That's hyperpolarization. The pumps happen. You get sodium on the right side. You get back, and you're ready at that negative 70 resting potential again for the next threshold to be met. So it just moves in waves, almost like all electricity does, right? Light electricity moves in waves. Sound moves in waves. And this electrical thing down the nerve moves in waves. So again, nature mirrors everything else. Or I should say everything else mirrors nature.
What's the dysfunction?
What is the dysfunction?
What does dysfunction look like? Is this perfection right here?
Yeah, this is a perfect action potential. So what happens, so the way we control pain, remember I told you to remember voltage gated? So if you can control that threshold of excitation, that means if you can control when the action potential happens in a nerve or doesn't happen, then all the signals going to the brain, which means you can control pain. So if you can do something that inhibits it, that makes it harder to meet that threshold, then the nerves aren't going to fire and you won't get the pain signal. And you can do this at any point. You can do it at the sensory level, the transmission level, or the central processing unit level. Okay, so why do we have myelin? Again, insulation. Insulation makes electricity run better. So basically, you keep the positive ions a little bit further away from the negative ones, because if you only have a couple cell layers thick of a cell membrane, they're going to try to congregate next to each other on the membrane either side. But if you have a thick fatty layer to separate them, then it's much faster when the sodium channel opens. All those congregated sodium ions at those gaps between the fatty layers will drop in much quicker because they're not sitting, resting, attracted like a magnet to the negative things inside the cell. They're separated by that insulation layer. They're only allowed in at the gaps, and it just makes the transmission more efficient. This is why myelin is so important and why demyelinating diseases cause pain and motor dysfunction and other problems. So again, you can see this. So that the blue bubble thing is, like you cut a nerve long ways in half. That's the thick fatty layer that goes all the way around the nerve actually. And then those little gaps have the pumps and the channels, and that's the only place the ions can move. So it just makes it much more efficient. So think of it like, think of it like if you had a huge funnel versus a smaller funnel, how much fluid you put in would go in quicker depending on the size of the gap, assuming that you had no other way for the water to get in. That's probably a terrible metaphor or analogy, I guess. Anyway, it separates the positive and negative ions, and then the spaces between the sheaths called the nodes of Ranvier, those gap junctions, that's where all the action happens, literally. The action potentials are created there. So when you have a demyelinating disease or something that takes away the insulin, I mean, not the insulin, the insulation for some reason, like multiple sclerosis or Guillain-Barré, then the nerves don't work properly. The signal's not transmitted correctly. The action potential doesn't happen right. This can happen peripherally in the nerves or centrally in the brain. And the insulation is called different things based on peripheral or central. Peripherally, they're Schwann cells. Centrally, they're oligodendrocytes in the brain. And you can get all of the things you think of with nerve dysfunction just from a poor insulation state of being. You can have weakness, pain, numbness, tingling, tripping, vision problems, headaches, anything. And then generally, people with MS notice weakness and pain distally, meaning far away from the body first, which makes sense because the axons, the long axons, obviously the transmission is going to be disrupted from the far away points before it'll be disrupted from something close by. So that's why the limbs or the peripheral things tend to be affected more quickly in these conditions. And so again, this all hinges on salt, sodium chloride, right? NaCl, a cation and an anion bonded together, which makes it a neutral charge. So the sodium chloride is concentrated outside of the cell, and then on the inside, potassium tends to bind to proteins, amino acids, which have a net negative, much more strongly negative than the chloride on the sodium chloride. So the potassium is bound to proteins inside, sodium's bound to chloride outside the cell. Effectively, you end up with more of the positive outside the cell than you do inside, and that allows you to have this action potential system. Okay, next slide. So salt is key. Salt is the only reason you feel pain, think, talk, do anything. That is why it is so important that we have salt and why humans for years have traded on salt. The word salary comes from salt. They used to pay Roman soldiers with salt. That's how valuable it is. And now you know why. Everything hinges on that particular cation doing its thing so that your brain can work. So again, remember the membrane potential. Positive outside, negative inside. You're at negative 70 on the x-axis there. That's where you're resting. A signal is received from the dendrite, from the synapse. Okay, something happens, dopamine hits it, says fire. So the channel's open and the wave starts happening. The action potential starts moving down the nerve. Channel's open, positive ions rush in. You get the spike in polarization, meaning that the inside of the cell becomes positive. It gets to be too positive, the channel's closed, everything gets reset. So this all hinges on having an effective sodium-potassium pump, which means you have to have effective energy, which means you have to have effective mitochondria. And remember, I've talked about how important the mitochondria is to everything. And if you have too much oxidative stress, chronic inflammation from diet and whatnot, and not having enough antioxidants on board, your mitochondria don't work well, which means guess what? None of your nerve cells work well. And so that's when you start having these random firings or this action potential doesn't look like this, that's when you start having problems, things like pain. Okay, and this is going on all the time, every which way in the body, up, down, crosswise, brain, peripheral, thousands of gigabytes of information daily in every single human, billions of neurons, and each are connected to many other neurons by way of the dendrites and the axons and the cell bodies. And if anybody can guess who this is, we'll give you a giveaway. I put him in here because this is an android from a very famous TV show, and I think everybody's scared to death of androids and AI, but at the end of the day, it comes down to this. Can you ever really reproduce how magnificent the human being really is? I'm not sure, maybe. We're not there yet. All right, next. Put the question? Oh, put the question in the comment section if you have a question, and then we'll answer them. Oh, Hillary got it. Data. Hillary Parsons, strong work. I'm making my kids watch Star Trek, and they think that we're crazy because my daughter today said, nobody watches Star Trek. Why do we watch it? I said, because you need to know Star Trek. That aside. All right, let's move on. Misty, all right, awesome. We'll send 2 giveaways. Next slide.
Tell Sharon, I see your comments. Go ahead and put your questions right there.
Okay, Sharon, keep putting your questions right there, my producer says.
We see you, Sharon.
We see you. Can we go to the next slide? This is a very long talk. I got to get through it. All right. So the synapse, super, super important, okay? The average size of the synaptic cleft, okay? Cleft just means between. So you've got this side of the synapse, this side of the synapse. That cleft is 0.02 microns. Honestly, I don't even know how small that is. It's beyond microscopic. It's teensy, teensy tiny. But just imagine, everything hinges on a little protein neurotransmitter being dropped or expelled, vomited, if you will. I'll credit Dr. Andrew Huberman for that term, from one side of the cleft to the other. So the neurotransmitter gets pumped out on one side, hits the other side, and remember, this is dendrite, right, to dendrite, or axon to dendrite to cell body. You have to have an adequate stimulus to trigger that spike in membrane potential to trigger the electrical charge. That is your threshold. So you either have to have enough of the neurotransmitter hit something, enough of a volt hit something, enough of a mechanical change hit something. Something has to stimulate that, right? So like, let's say the world's tiniest feather touched me. That might not be enough to tell the receptors in my fingertips that something has changed and then tell my brain I just felt something. Versus, if I whacked my finger with a hammer putting a nail in, obviously that's going to be enough of a stimulus. So the threshold is everything in pain. So there's subthreshold. So you can make it so the nerve will fire with very little change in membrane potential. You can make it so it'll fire with a much higher change in membrane potential. So that's how you can modify pain signals, or one way you can modify them. The other way is to change the number of neurotransmitters passed from the synapse, either way. And then also, the body has this amazing recycling system. Again, why sleep is so important, to clean everything up. But each of the neurotransmitters that are released are reuptook or reuptaked. So there are reuptake inhibitors. A lot of the antidepressants are serotonin reuptake inhibitors, SSRIs. And that's because they block the serotonin that's been released across the synapse from being recycled, which basically modulates how the signals work in the brain. And neurotransmitters, they're the same, whether it's depression or pain or excitement or rage or thinking. There's only so many neurotransmitters. They're all the same. That's why a lot of times we can treat pain, believe it or not, using an antidepressant medication. It's pretty cool because it's the same neurotransmitters. Anyway, once you meet that threshold, you have an action potential. It is all or nothing. There's no half-seas action potentials. There's no double action potentials. You either meet that threshold or you don't. So when the action potential reaches the terminal bud, so that's the synapse, right? So the synapse from nerve A is the terminal bud. Calcium rushes in, okay? So there's your other important mineral for communication. We've talked about this before. Calcium is extremely important for cellular communication. Calcium changes a volt, receptors open, little balls filled with neurotransmitters open from that voltage coming in, and then the neurotransmitters are released. They cross the synaptic cleft, they bind receptors on the other side, more channels open, the positivity, negativity is changed, you have an action potential. So these receptors in synaptic clefts are very, very important. I'll give you an example. One of the ways that Botox works is it stops the reuptake of acetylcholine at this cleft. Acetylcholine is extremely important for motor function, for muscles to work. So if you can stop the acetylcholine from triggering action potentials, you've effectively stopped a muscle from working. And so that's how Botox can stop wrinkles and stop spasticity in people with, spastic paralysis after a stroke or whatnot. Okay, let's go on. Okay, so here, that top picture is an actual electron micrograph. It's been colored, obviously, of a true synapse. I mean, it's just pretty magnificent how the body works. And if you think about it, it's all just three-dimensional, messy, with time and just explosions happening at the cellular level, just massive amounts of change and electrical charges. But you just have no idea this is going on all the time in your body, and the reason why you feel anything more or less pain. So the neurotransmitter binds the postsynaptic, so it's across the cleft, it binds the postsynaptic receptor. They change shape. That's what receptors do whenever they get a certain stimulus. So remember the pump, until the sodium gets it and the energy hits it, it's like this. Once the energy and sodium's in, it changes shape. So they change shape, triggers something to open, and then you meet your membrane threshold potential, you have your action potential. And then this just keeps going down the nerve. And it takes only about 0.5 to 4 milliseconds for these neurotransmitters to be recycled for the next signal. So this is just happening more rapid than I can ever hope to imagine. These are some of your neurotransmitters. You may have heard some of these terms. This isn't a full list, but glutamate, the most important excitatory neurotransmitter, so very important for pain. Glutamate gets things hyped up, hyper. It's like having a guitar string that's so tight when you hit it, it breaks. That's people with really high tension set nerves. They're probably in a hyperglutamate sort of a situation. PGE2 and PGI2, those are prostaglandins. You may have heard of prostaglandins. This is why ibuprofen works. Celebrex works. Steroids, it shuts down the prostaglandins, which don't stimulate the nerve, which doesn't let you have a painful action potential. So on and so forth, all the way down to dopamine, histamine, which is your allergic response, noradrenaline. And then on the inhibitory side, your opioid peptides kind of shut everything down, glycine, cannabinoids, serotonin, but some of these can also be excitatory. I'm just keeping it simple here. And then GABA, which is an extremely important inhibitory neuron, very natural. You make it all the time on your own. It's in our sleep gummy for a reason, because it helps balance out the hyperglutamate state. Okay, so remember, I told you to remember voltage gated and threshold. Very important for pain. So the threshold potential is the value, the charge value, so negative 70 millivolts, your resting membrane potential. The threshold whereby it becomes a bit more positive, when it hits a certain number, that's when you're going to get that action potential. If a tissue is excitable, like a lot of glutamate or whatever genetic gene is being transcribed to make it very, very excitable, that threshold will be about 10 to 15 millivolts lower, okay, or less than even the resting membrane potential. So basically that means you're always firing. So if the threshold for an action potential is even lower than the resting membrane potential, you could imagine that that would make a nerve very neuropathic and quite painful. So you have to be able to maintain a normal resting membrane potential, which means you have to have the right number of sodium, chloride, potassium, proteins, an effective cell membrane. All the neurotransmitters need to be in balance, so on and so forth. I just threw this on the side, the Nernst equation, because some of you may be thinking, well, if it's osmosis and there's a lot of particles here and particles there and a lot of charge here and charge there, how does that work out? There's actually a balance. So it's not just the charge on one side and the other, but the number of particles too. It all has to balance, and each molecule has its own number for the Nernst equation, where you can have X amount of charge with this many molecules, and it'll balance with the same thing on the other side. So it's not just the charge, but it's actually the physical molecule, the number of them as well. So quickly to review, we've got a resting membrane potential of negative 70 inside the cell, primarily because of amino acids, right? The sodium channel is shut. The action potential happens. You get enough of a volt to come in that you meet that threshold potential, in this case, negative 55, and it triggers the sodium channels to open, sodium rushes in, you get an overshoot, hyperpolarization, it becomes very positive in the cell, then the sodium channels shut, the potassium tries to go rebalance where the sodium was, and then you have the pump that takes sodium and pumps it out over time to build that same resting membrane potential. Now, this sounds like it would take forever, but it takes like milliseconds. And then that's how the body propagates a nerve signal. And this just shows you sort of in pictograph how that's working. We can go to the next slide. We've talked about that a lot. Okay, so basically you're thinking, well, we just took sodium from outside and put it in, and then we put potassium from inside and put it out, but they're both positive. So what do we really do? The reason this is cool, and the reason why it doesn't just have channels that let sodium in and potassium out and so on and so forth, is eventually you would reach neutral in that situation if you didn't have an active control. And worse, if the channels were the only thing regulating the membrane potential, then that would mean the electrical signal could go either way. Well, we definitely don't want that. You want the electrical signal to go one way or the other. You want to know something touched my hand, right? It can't go both ways. Your brain can't tell your knee to move when you're running and then also have it go back the other way. So this is what's called a refractory phase. So there is a time period during which you cannot have an action potential. And that's when that sodium channel pump is pushing everything and getting you more sodium on the outside and potassium on the inside. That is the active way that keeps the signal from going either way, okay? And you have to have a sodium pump. It won't work with any other ion. So it's all very specific. So the pump is going to make sure that it's sodium. The action potential is only going to happen through a sodium channel. So even if you had a ton of potassium outside, it's not going to give you an action potential because there's no potassium channel that works the same way as a sodium channel. So it's kind of ingenious, kind of amazing, and it's fail-safe in most cases. Okay, so what does this mean for nerve pain? Why are we doing all this basic science? Really just because it's cool, but it also helps you understand pain better. So remember, pain is just a perception. Pain is a symptom. Pain is not really anything. It's what your brain says it is. So you know that silly pain scale that you always have to do from 1 to 10, or the silly smiley faces, which has been studied extensively and found to have no inter-observer reliability, FYI, but it's all we have. And of course, it was forced upon us by OxyContin, et cetera. We won't get into that. But basically, what to you might be a 2, I might think is a 4. Or what you might think is a 10 out of 10, I might think, you'd have to be on the floor, writhing in pain, bleeding out to be a 10 out of 10. So a lot of what we perceive as pain has a lot of different factors that come into it, from how you were raised to think about pain, any childhood trauma, culture, and then of course, how inflammatory your system is, how much oxidative stress do you have. Everything matters to how your brain interprets the electrical signals as to whether they hurt or don't hurt, or how much do they hurt. Okay, so pain is usually carried by what are called C fibers, and generally they're unmyelinated, believe it or not. They're very small. They're not as efficient as most of the other fibers in our body. And they can be heavily changed just by changing the relative concentration of ions.
I can't stand that pain scale question.
Yeah. The pain scale, I think, is one of the big problems in medicine, I will say, because it's so inaccurate and it makes no sense because everybody's different. And honestly, the first person that comes up with a way to truly measure pain, they'll probably be richer than Elon Musk. But to date, it is so subjective. We never have any idea what it really means when we ask someone if they hurt. I mean, I don't even know like how my mom feels when she hurts, and or anybody in my family. So it's just such a terrible system, but it's so subjective. We do look at things like if your heart rate goes up, if your respiratory rate goes up, are you sweating? There's different physiologic responses to pain that help us understand how much pain somebody's in, but generally it's all by self-report. And you can imagine sometimes that's going to be very accurate. Sometimes it's going to be completely inaccurate. But that's our job to figure that out. We have a question. Okay, Sharon.
I have Gordon's neuroma.
Mm-hmm.
How can I cure it without surgery? Or is it just better to lose the nerve through surgery?
Okay, so Sharon's question is, I have a Morton's neuroma, and do I have to have surgery, or is there some other way to treat this? So a Morton's neuroma is when the digital sensory nerve to the toes becomes deformed, kind of globular, and damaged between the long bones of the toe. And so most people feel it sort of in the ball of the foot. It may or may not radiate out to the toes. It may or may not radiate up to the foot. Some people say it feels like a sock or a rock is stuck in their shoe all the time. Anyway, that nerve's pure sensory at that level. Surgery does work. I do that surgery for people. But I try with physical therapy first, with nerve glides, nerve flossing. There's a lot of techniques that a good physical therapist can do to reduce nerve pain. And then I try things like omega-3s, PEA, different substances to reduce the inflammation around the nerve ending. If you offload that area where you're always walking on the ball of the foot, so I don't know if you guys know, but I have a flip flop called the Healing Sole that I made to treat foot pain. It has this special type of arch support that offloads the ball of the foot for that particular reason. So if you can take compression pain off of a nerve, it can help. Met pads, you may have heard that term, that you put in an insert, offloads that nerve position. So there's a number of ways you can treat it, and even down to injections. Some providers do a series of alcohol injections, which I'm not a big fan of because I just can't comprehend how the alcohol is not damaging everything normal around the nerve. Steroids are used a lot, but those cause skin depigmentation, muscle atrophy, tissue weakness. They cause changes at the genetic level, so I'm not a big fan of steroids. So I'll do like Toradol injections to diagnose and lidocaine, and then physical therapy, getting in a 0-drop shoe to take pressure off the forefoot, met pads, anything to offload that area. At the end of the day, if all that fails and you need to have the surgery, the good news is it's a quick surgery, no downtime, and that nerve is pure sensory. So all you lose is sensation. You don't lose any motor function. All right. That was a long answer. Sorry. Next. Okay. So here's the meat of how we control pain. So back in 1965, this is how old this is, Melzack and Wall came out with this theory called the gate control theory of pain. And you can imagine that's exactly what it sounds like. If you can control that gate, that lets the action potential happen and lets the sodium in or out, then you can control pain. And what they've proposed, which has proved out to be more or less true, and of course there's been some, as in all science, disagreement, alternate theories, criticisms, yada, yada. But really, this is a solid theory that works really well. Non-painful stimuli can close the gates to painful stimuli. So this is like if you ever get a paper cut or something stings you like a bee, you notice you instinctively grab wherever you were hit and you start pressing it, and it doesn't hurt as much. Well, the reason that's working is because the stimulus from the pressure is overpowering the stimulus from the pain. So the fibers that carry pressure and vibration are thicker, myelinated. They work better than the pain fibers. So if you press something or rub it when it hurts, that's how you can modify the pain signal that your brain's getting. Okay, Dr. Melzack himself said pain is in the brain. So you can completely control pain if you can control how these electrical signals are sent and interpreted and modulated along the transmission line. So pain will start in a receptor, like something you cut, let's say you cut your skin with a piece of paper. There are afferent cells that sense that, oh, something just changed. It's a mechanical movement of the skin cells and membranes ripped apart. They fire, they meet their threshold. Then it transmits to the brain, and the brain interprets that particular signal from that particular receptor in a certain way, and it says, oh, I just got cut, versus, oh, I just got burned, versus, oh, that's really cold. So it all has to do with the type of neurotransmitter, and then the type and the electrical signal, and from which cell it goes to where it goes in the brain, how it's interpreted. So it's pretty magnificent if you think about it, and you can control it just by controlling if you could control the gates. So if you have gate control, then you have pain control. So here's the gate control in action, and these two diagrams sort of show you. So the C fiber is your pain fiber, and then you've got your A beta fiber or alpha, the big fibers that carry like pressure, we'll say. There's an inhibitory interneuron between them, okay? If it's working, then the big fibers from when you press on the cut hit the projection neuron, which is going to transmit it to the brain as the C fiber does, but they're stronger, so the pain signal doesn't get transmitted. Conversely, if you inhibit the signal from pressing, like if there's an inhibitory neurotransmitter of some sort that allows the excitation of the C fiber to occur, then you do get projection of the pain. So if you can modify the threshold to meet the action potential and or the neurotransmitters at that synaptic cleft, you can modify pain. And so rubbing or pressing an area, that's a simple instinctive thing we all do. A TENS unit, that's how TENS units work. Transcutaneous electrical nerve stimulation. So you put the pads of the TENS unit on and it sends a low voltage current and it changes that threshold. So the threshold cannot be met. You're basically tricking your brain and you don't feel the pain anymore. My favorite way to treat nerve pain nowadays, because it is just so effective, it's almost magical as a peripheral nerve stimulator. So I'll actually implant these right next to a nerve that I know is hurting. And there's a series of steps we go through to prove that that nerve is a source of pain. Once we prove it, let's say the tibial nerve, the median nerve, perineal nerve, suprascap, whatever peripheral nerve is a true source of pain. If you put this little lead, this little electrical lead right next to the nerve, and then there's this wireless receiver outside that a patient would wear periodically, and it sends a signal to that lead, you can stimulate the fibers and stop the C fibers from sending the pain signal to the brain. And then you can actually use mindfulness. This is how yogis do it. This is how all of the pro athletes now do it, with biofeedback and mindfulness and changing your mindset. And you can literally just tell yourself it doesn't hurt. That's a very simplified way to think about it. But think about this. You know how when a car door slams on a finger, a lot of people don't notice it right away. It doesn't hurt. Well, why is that? Because the shock and the distraction and everything else is overpowering the pain signal. So there's many ways to train the brain. There's cognitive behavioral therapy is massively effective for chronic pain, much more effective than narcotics. But of course, it's a service. It's hard to get coverage. The profit margin's not the same as with drugs, obviously. But don't forget mindfulness training, mindset, cognitive behavioral therapy, all these ways to control how the neurotransmitters work up and down, help you control that gait and give you gait control. We have a question.
Hillary.
From Hillary.
Are there any treatments for post-herpetic neurologica aside from lidocaine and narcotics? Hold on, backstory.
Okay, hold on.
Antidepressants. They've been unsuccessful for her mother who's suffering from this for 2 years post-shingles disease.
Okay, Hillary has a relative who has a 2-year history of pain from shingles. So it's called post-herpetic neuralgia. Shingles is a herpes virus. So post-herpetic means after the herpes virus flares. Neuralgia means the nerves are damaged at that point, that they're hyperexcitable and they're always firing. They're always sending pain signals. So the herpes virus lives in nerves and it'll just show up randomly in periods of stress. Anyway, that's shingles. So post-herpetic neuralgia is continued pain. Lidocaine is traditionally used for this, of course, because that's the only thing covered, and even in those cases, not always covered. I've known people to go on medical marijuana for that very successfully. And if you can isolate it to a single nerve or a couple of nerves, you could do, in theory, a peripheral nerve stimulator for that. For chronic nerve pain of that sort, anything you can do to alter the GABA to glutamate ratio would be helpful. This is why people prescribe things like gabapentin, Lyrica, etc. Or you can take natural things like GABA. I'm not going to say it right, PEA, palmitoyl ethanolamide. This is a natural fatty acid amide that your body produces at peripheral nerve endings to reduce inflammation around them. Basically stops mast cells, which are white blood cells, from spewing forth all of their prostaglandins and whatnot. So PEA is a great natural way to treat things like arachnoiditis, post-herpetic neuralgia, just these chronic nerve-based pain things. And then mindfulness training, meditation, transcendental meditation. But you have to have somebody that really understands and can train your relative in that. And then capsaicin. I've used that for people because it basically trains the nerves, or it gets rid of the neuroreceptors from what are called the TRPV1 receptors. And capsaicin will actually deplete your system of neurotransmitters so pain can't be propagated. There's a number of different ways to handle that. Well, yeah, the question is, if you don't want medical marijuana, would delta-8 work? Yes, because it's just one molecule different. But anybody that's out there tested or has an HR issue with medical marijuana, I always recommend don't take delta-8 because you will test positive anyway. All right, next. Hold on. Okay. Okay, we sent a link out to all the supplements I recommend for nerve pain. One of the best is omega-3 fatty acids, believe it or not. Next slide. Okay, so these remember the ion channels I told you about? Sodium in, potassium out, et cetera, they can open to direct stimulation from GABA, acetylcholine, serotonin, glycine, any neurotransmitter really. Excitatory neurotransmitter open the positive channels. Inhibitory transmitters open the potassium or the chloride channels to get the balance back. So excitation means you're either going to be putting a ton of sodium outside so it drops in quicker, or you're going to do something to make the sodium channel open quicker. Anything that basically gives you that action potential faster. That is an excitatory neurotransmitter. And then the opposite is true is for inhibitory neurotransmitters. Neurotransmitters can be both inhibitory or excitatory, depending on anything from the time of day to what you ate to your mood. I mean, it's impressive. So don't get hung up on GABA inhibitory, dopamine excitatory. Sometimes it's a little bit different in the human body. For instance, serotonin, we always think of the calming, feel good, kind of mellow neurotransmitter, but it too can be excitatory at times. So this is an example that's pretty interesting of inhibition of neurotransmission. So remember, the chloride is usually blocked. Remember, sodium chloride, it's outside the cell. It's usually blocked from going in. The channel's closed. First of all, it's already native inside the cell because of those amino acids, so why would chloride want to go in? But also the channel's closed. So an inhibitory neurotransmitter can open a chloride channel and let negativity come into the cell. Well, what happens if negativity comes into the cell? Well, then you go from that resting membrane potential of negative 70 millivolts to like negative 80, negative 90. Well, what does that mean? Well, it's going to take more to get you to where you meet that threshold to fire the action potential, right? So if you're supposed to start here, the volt comes from the next nerve and it fires and you shoot an action potential. Well, if you're down here, it's going to take 2 or 3 signals to get you up here to fire the action potential. That's how inhibitory neurotransmitters work. Glycine, for instance. Strychnine, and I put a picture of an Agatha Christie old mystery novel where the killer used strychnine. This is a poison. It binds the glycine receptors and blocks the action of the glycine neurotransmitter, okay? Which basically makes it easier to fire an action potential. And so these people, when they're poisoned with strychnine, have convulsions, muscle spasms, and basically die because they have uncontrolled excitability. And then alcohol does the opposite. It lets more chloride in, and then it makes it harder to fire a neuron. That's why it gets sluggish. Things don't work well. You can't think right. You have cognitive decline, et cetera, et cetera. So it increases GABA receptor activity. All right, next. I mean, if it has to do with nerves.
I don't know. She has 8 compression fractures in her back. What does she suggest? She's here in her lower back. She wears a brace and she does not take pain pills.
Yeah, we just got a complicated question. Somebody has back pain with multiple compression fractures in the lower spine. They're wearing a brace, not taking pain meds. She wants to know if there's anything else to do. Compression fractures imply that if this is the front of the body and this is the back, that you're sort of in that forward X position. One thing I try to do is put people in therapy to really strengthen all of the posterior back lines and the posterior leg lines and the posterior arm lines and neck lines to sort of counterbalance that forward flexion position. Braces tend to make people weak over time. So bracing short term, I'm a huge fan of. Long term, I think it generally weakens people. So I would start with physical therapy personally. All right, what is hyperalgesia? Okay, remember I told you pain can change depending on if you meet the threshold early or late? Well, when the threshold to fire drops, so it goes from that negative 50 to say negative 60, well, it's easier to meet it, right? So the action potential is going to fire in the nerve pain fiber, and you're going to get that signal in your brain, which your brain is going to say is pain, quicker. So hyperalgesia is when you feel more intense pain for any given stimulus. So like, let's say I took a hammer and I whacked my hand. That should hurt a certain amount. But let's say I then, a few days later, took a pencil and tapped it. If the pencil tap feels the same as a hammer whack, that's hyperalgesia. Okay, and that's from damage to the nerve itself. Either damage to the receptors, altered neurotransmitters, the membrane itself is not functional, the channels aren't working, or the signals from the pain receptor through the transmission line to the central processing unit of the brain, something's happening in the brain that is making it get interpreted poorly. And that's called neuroplasticity. And that can go either way. You can become more sensitive to pain or less sensitive to pain. Hyperalgesia is an exaggerated response to a usually painful stimulus. So sure, it's something that should hurt, but it should only be a 5 out of 10. It shouldn't be a 10 out of 10. Again, using that terrible scale. Hyperalgesia is extremely common in people that use narcotics. This is one of the big dirty secrets of the narcotic world. If you give somebody narcotics, you can almost guarantee they're going to hurt more. You can then prescribe them more narcotics, or you can then indicate them for surgery or whatever you want to do, because opioids change this balance and they make it easier to feel pain, ironically, paradoxically, however you want to look at it. They also cause what we're going to talk about next, which is allodynia. Allodynia means that something hurts that should not hurt. So I see this a lot in my patients that have fibromyalgia. So if you just touch them, just a gentle touch, it hurts. Well, that is not what should be a normal painful stimuli, as opposed to whacking your hand with a hammer. That should hurt. But just doing this should not hurt. People with allodynia, it does hurt. Again, associated with opioid use to a great degree. This is post-herpetic neuralgia, we already talked about it, and diabetic neuropathy. This is when the nerve's so dysfunctional, or the brain processing is so dysfunctional, that things that shouldn't hurt start to hurt. So what's been found in the literature is a lot of people that are on chronic long-term narcotics, if they detox for about a month, 4 to 5 weeks, get off the narcotics, they actually have less pain than they did when they were on the narcotics. And this is why, because you reset that membrane threshold and the voltage gated firing of the action potential, and they become less allodynic and less hyperalgesic. Next. All right, I see allodynia all the time. You see it in people with fibromyalgia, trigeminal neuralgia, which is pain in sort of the face region, diabetic neuropathy, I see it all the time. And then migraines are associated with the allodynia. All of this from nerves firing the threshold set a bit too low. So you can sensitize nerves. So this is one of the reasons we think people get chronic pain. They get a sensitization of the system where it fires quicker, harder, more easily, okay? So this is, you have to have a change in that threshold that is needed to produce the action potential. That can be from the fluids surrounding the cell might be highly inflammatory. You might have a lot of oxidative stress to the protein structures. The receptors might be damaged. The cell membrane might be damaged. Anything. And then pro-inflammation or pro-inflammatory mediators can trigger these channels and then have cations moving back and forth non-selectively. This is how the TRPV1 channel, so that is actually a channel that's triggered by heat and cold, specifically heat. This is why when you eat hot peppers, it feels hot. You're triggering these receptors that are letting a certain number of ions in to fire an action potential. But if you have enough inflammation around these things, they fire all the time. Capsaicin depletes the area of the neurotransmitter, and then it depletes the ability of a signal to cause that threshold change to make the action potential. So that's how capsaicin works over time. It actually makes things worse short term because all these receptors are let out, but once you get through that phase, then you have less pain. So what is pain? This is literally the definition from the International Association of the Study of Pain. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What does that mean? Basically, think of it this way. You don't like it. It's heavily involved with emotion, mood, and mindset, and it may or may not involve tissue damage. So that's what I'm saying. So pain does not always mean badness. Sometimes pain is just pain. It doesn't mean that things are about to fall apart and break. Plenty of people have pain for no apparent reason. Neuralgia is pain in the distribution of a nerve or nerves. Neuritis is inflammation of a nerve or nerves. And then neuropathic pain is generally considered to be pain that's caused by some type of a lesion, either compression, damage, stretch, slicing, whatever, to the nervous system. We have a question? We have a big question.
Carrie wants to know, how do you survive for 5 weeks that you're trying to detox from morphine and oxycodone? The doctor has me on peripheral mode.
Oh my goodness. Okay. What was the name? Carrie? Carrie had a great question, and honestly, I see this all the time, sadly. The question is, how do you detox off of OxyContin and morphine for 5 weeks if you've been on it for a long time for neuropathic pain? And her doctor put her on this, which is not uncommon, sadly. It's hard. I'm not going to say it's easy. There's a great book called, I think it's called Dopamine Nation by Anna Lemke, who's a Stanford addiction specialist. I want to say Stanford. That's a great book you could read that kind of explains the process of addiction and getting off of a certain med. And I'm not just mental addiction, but physical addiction. It usually for anything from sugar to narcotics to gambling, you name it, whatever has addictive potential and ends with olic, alcoholic, whatever, workaholic. It usually takes about 5 weeks for the brain to reset. The first 2 weeks are miserable. Then it starts to get easier and easier. And if you do it correctly, at the end of 5 weeks, you should no longer have that craving and your system should not need it anymore. But it's not easy. When I detox people off of narcotics, I do it way more slowly. I usually make it take months and start reducing. Let's say you took 4 Percocets a day. We would go to 3 3/4 for a month or 3 for a month. And then, enough of a change that you don't really notice it. And then you do that again and again and again. So it's like a long staircase down. That way you don't get any of the withdrawal symptoms. The body has time to reset all these receptors, to reset the membrane potential and the voltage gated threshold. It takes a long time, but it's totally possible. But I wouldn't try to do it myself because there's a lot of side effects. Like normally people on long-term narcotics are constipated. So when you come off, you get diarrhea, things like that. Sweating, emotional lability, like the brain just goes haywire. So it needs to be done slowly, carefully, and guided. But generally, once you get off of the narcotics, you don't hurt as much. I know it makes no sense, paradoxical, but that's just been shown over and over again. Next. Oh, like alternative? Yeah, so as people are processing off of narcotics, I will add other things, which I'm sure this person's already tried, most of the synthetic drugs like gabapentin, Celebrex, muscle relaxers, Cymbalta, Celexa, other antidepressants. So you can upscale alternative meds as you downscale the narcotics. And then I'll add natural things like omega-3s, PEA, tart cherry, turmeric. Sometimes I use CBD. Sometimes I recommend medical marijuana. There's a variety of natural medications you can use to tamp down the excitability around these membranes to reduce that threshold from being met. And then, of course, TENS units, physical therapy, mindfulness, and then peripheral nerve stimulators they've been awesome. For neuropathy, yep. Another question? Okay, nerve pain. So neuropathy, remember, it's a disturbance of function or a pathologic change in the nerve. It could be one nerve, it could be several nerves. This is about 2.4 or so % in the normal population. It's 8% in the older population. So I see a lot of what's called small fiber neuropathy, which you really can only diagnose with a skin biopsy. In people that aren't diabetic or have no reason to have neuropathic pain, but they do. And it's just from long-term chronic change to the function of the nerve, which comes back to what we always talk about here. This comes back to diet, lifestyle, lack of sleep, too much stress, oxidative stress, and then also chronic inflammation. So there are ways to sort of control the damage to your own nerves, giving the nerves what they need to function properly and keeping them away from toxins. Diabetes is a big problem because of the hyperglycemic milieu, if you will. There's just too much sugar floating around everywhere, and that binds to proteins and gloms up, turns into sorbitol, causes all kind of nerve dysfunction. Similar things happen with chemotherapy. Alcohol is a known toxin to nerves. So lack of vitamin B12 specifically can cause these kind of neuropathic things. So there's a variety of problems. I see it often with D deficiency. There's D receptors everywhere, including nerve cells. So if you're D deficient, you hurt more. And that's just been shown in study after study after study, highly associated with chronic pain. So these are places I start. We run a whole panel on people to look for whatever deficiencies they may or may not have related to nerve pain. And we address those as we do all of the mechanical treatments of the nerve pain as well. What is a peripheral nerve stimulator is a question from Carrie. That is the implantable lead I talked about in the beginning of the talk. It's like think of it like a tiny little filament, and I actually put it on a nerve, wherever the nerve is, under the skin. So you don't even know it's there. Then you wear this little wireless receiver with adhesive, and it sends a signal which stimulates the nerve and overpowers it so that it can't send its action potential. So that's that gate control theory. So you control the gate by closing it, by stimulating with this voltage to alter that threshold. So I perform this particular procedure in surgery. I don't know if it's permeated into the mainstream yet. It's I want to say relatively new technology, but we've been doing it for a while and it's been very, very effective. But it is a procedure. You do need to test it first to see if it's even going to work for someone. But for people that have failed literally everything or so far gone with their nerve pain, I think it's a great option. Honestly, it's for those people, it's the only option because at that point you've done everything. But now that we have this, it's been incredible. Okay, next. Okay, so remember, what is nerve pain? Pain, numbness, weakness, loss of reflexes. You can have motor dysfunction, you have cramping, you can have restless legs. There's a whole continuum of problems when nerves are dysfunction. It's not just straight up pain. You can just feel weird, it's uncomfortable. There's like a pillow in my shoe. Why is there a balloon? What am I walking on? So it's just all from nerve dysfunction. These are the things that can cause it, which somebody out there is going to have one of these. Diabetes, we know. Chronic alcoholism, we know. Any inflammatory condition, to include any and all autoimmune disorders, because those are by definition inflammatory conditions. Nutrient deficiencies we talked about. Hypothyroid, huge source of nerve pain. Thyroid receptors are found throughout the body. Thyroid hormone is massively important, as is cortisol and melatonin, as is D3. Autoimmune, we talked about that. Infections can do this. Postherpetic neuralgia, EBV or Epstein-Barr virus, Lyme disease, which is actually not looked for a lot, but a lot of people have post-Lyme pain. Toxins, chemotherapy can do it. Lead in the water can do it. Tumors or compression on a nerve. I see a lot of nerve entrapments in the ankle and the foot and the wrist and the elbow, and then there's some nerve entrapments that happen in the shoulder, and all that means is some other structure in the body is jammed up on a nerve, and nerves don't like that. And then they start ectopically firing and telling your brain, get this thing off of me. So I do a lot of nerve release surgery. And then inherited neuropathies, these are things like Charcot-Marie-Tooth disease you may have heard of. There's about 300 different neuropathies, and they each have their own little way to diagnose them. Ehlers-Danlos disease can do this because that's a connective tissue problem. Different medications can cause nerve pain. Multiple myeloma, the list goes on. And then my favorite, idiopathic, which if you look at the first four, idio, it's sort of like idiot. Idiopathic means the doctors have no idea why you have this nerve pain. So we're just going to call it idiopathic. So next. Diabetes. About 50% of diabetics have neuropathy. Okay, the range in the literature is from 18% to 65%. It's more common in those that are chronic and not treated well, but believe it or not, neuropathy is actually more common in the pre-diabetics. Why? Because they're living in this hyperglycemic state that's just not high enough to hit that number where the hospital system says you have diabetes. But really, you have a big problem because you're running around with your sugar too high. And those people get a lot of neuropathy even before they're diagnosed with diabetes. Well, here's the problem. Only if you're diabetic does insurance cover anything for your feet to treat this kind of pain. So it's almost like you have to get that diagnosis to get treated. But you really want to treat it when you're pre-diabetic, right? So it's kind of one of the many conundrums we deal with in medicine when dealing with insurance companies. Then you've got reduced signal transmission to the spinal cord. Okay, a lot of diabetics have a depressed reflex at their Achilles, and then sometimes even the knee, but very common to not have an Achilles reflex. I see this all the time, get misinterpreted or misdiagnosed as a sciatica or a lumbar radicular lesion that's causing a depressed Achilles reflex, and then these people get indicated for surgery when really it's just their diabetes. It's very sad and unfortunate. Alterations in gene expression patterns and channel properties. Remember the channels, whether they open or close. Well, that activity and then what molecule they're going to let through is regulated by the genes, which are regulated by DNA methylation, which comes from epigenetic modifications from diet, chronic inflammation, oxidative stress, et cetera, et cetera. And so you can see how hyperglycemia can do all of this. It increases inflammation. So you have more of these inflammatory prostaglandins and whatnot, changing the membrane threshold. You've got oxidative stress that's causing different products to be released that are irritants and also changes the cell membrane, also damages the DNA. damages a protein of the receptors. You've got glycation, which is advanced glycation end products. So the sugar gloms on to the protein of the receptor, free amino acids, totally changes how everything works and can make all the tissue thick and dysfunctional. That alone can cause a lot of nerve compressions and neuropathic changes in diabetics. I see it all the time. Very thick, scarred connective tissue, and that sometimes requires a surgical release. And then the polyol pathway is just a different way all this free glucose floating around is managed, which damages nerves. So diabetic peripheral neuropathy is a huge problem, getting bigger and bigger. More and more people are diabetic worldwide, especially in America, and we're just going to keep seeing more and more pain, unfortunately. We have another question. Okay, the question has been posted.
What is your recommendation for nerve entrapment? My right arm falls asleep nightly, but I sleep on my left side. It remains painfully. Sleep on hair for hours upon waking from the brachial plexus to fingertips.
Okay. Somebody's asking about nighttime arm pain from the brachial plexus, which is when all the nerves leave the cervical cord, they kind of group together, go through the armpit and go out to the hand. So, C1 through 8 or whatever comes out, connects certain ways, and you'll end up with the median nerve, the ulnar nerve, the radial nerve. So if you're sleeping cattywampus and compressing the brachial plexus at night, generally your body has this ingenious way of making you move at night so that you're not compressing one particular nerve at any given time, like their subconscious sensors. So something's not letting you move around at night, or you're moving and you don't know about it. But if you really think you're not moving at night, you may want to get that explored. I've actually started sending more and more of my patients for sleep studies because I think one of the keys to good health is good sleep. So that might be a place to start to see what is really happening at night, because obviously you're not going to be fully aware. But a brachial, if you're getting compressed at the brachial, the conglomeration of nerves from the cervical spine at the brachial plexus, that sometimes you have to do special MRIs of that area to see what is actually pushing on the lesion. I would suggest a nerve conduction study to see what's really going on, because that measures the electrical transmission, and you could actually find a conduction block, which is what an entrapment does. It slows down the conduction of the signal when you're doing that particular test. That's a whole workup question, a little bit difficult, but there are specific MRIs for the brachial plexus, and there are nerve studies that can be done. Okay, so we're going to quickly talk about how does a nerve get damaged, just so you understand this, because it's easy to say, oh, you have neuropathy. Well, what does that mean? So there's segmental demyelination, Wallerian degeneration, and axonal degeneration. And this is when, if you have a damaged nerve, you have what's called ectopic firing, and that means action potentials are happening when they should not be happening. And the ongoing pain can be blocked by blocking any peripheral input. So anything you could do to control that firing, that ectopic firing, will help. We think the pain from neuropathy is caused by the ectopic firing of the nociceptive pathways. Nociception means sensing pain or sensing something noxious or something that you should not be sensing, okay? And this is a safety mechanism. Think about this. There's actually something called the congenital insensitivity to pain. That is a condition that some people are born with, where they're missing this sodium voltage 1.7 channel, I think is the one they're missing. And they actually don't feel pain. And it is really hard to survive as a human being without being able to feel pain. Just think about it for a while, and you'll realize how many times a day you move or avoid something or change something because it's uncomfortable. And that's all safety mechanisms. So the primary afferent fiber, that's sensory coming in, the brain processes it, tells you, yeah, I hurt or not. And then, different things happen peripherally to manage it. So again, we have ectopic firing of the nociceptive pathways, and this is from a clustering of these voltage-gated sodium channels. So there's a series, 1.7, 1.8, 1.9, that have been discovered. So there's not just one sodium channel, believe it or not. And then if you have a bunch of them and they're not working right, that's when you get pain, or one of the reasons you get pain, okay? So I'm going to show you some pictures of how this demyelination happens. So segmental demyelination is when the myelin sheet degenerates itself. So that fatty insulation just starts falling apart for whatever reason. In this case, the axon itself is spared, so that process coming off the nerve is fine. It's normal. It's the insulation that is messed up. This is when you get sensory and motor neuropathies. So you could think of it almost like a peripheral neuropathy. This is like your Charcot-Marie-Tooth, your hereditary neuropathies. 20% of symmetrical peripheral neuropathies are segmental demyelination. And you can see the little illustration on the bottom. The top one is normal with the Schwann cells making the myelin. You've got the nice myelin sheath, gap junction, myelin sheath, gap junction, so on and so forth. The bottom one, the myelin's messed up, and you don't have that gap junction anymore. Now the positive and the negative ions are going to spread out a little bit more, and you're going to have no ability to efficiently propagate an action potential along a long axon. And this picture up top shows you microscopically a normal motor axon with that nice thick myelin, and then one that's got segmental demyelination. And you can see it's almost like taking a wire and cutting off the insulation in one place and thinking it's going to work the same way. It just won't. Wallerian degeneration is when there's a compression of an axon or some sort of lesion. So like it's cut, or like a cyst or a tumor is pushing on it. This is when the axon itself degenerates. So it's not just the insulation, okay? So this is when you'll get weakness. You'll get atrophy of the muscle. You'll get skin changes because the autonomic nervous system can sometimes have this too. And generally speaking, the axon will fall apart distally, far away from the cell body versus close. Why? Because the nutrition there is generally less, the blood flow is less. So it's easier for something to fall apart from a vitamin or a mineral deficiency or some protein or oxidative stress than it is closer to the cell body, because the cell body can help repair it the closer it is. So this is why people with diabetes, HIV, hepatitis, Guillain-Barré, they all start having problems at the toes and the fingertips, and then it just sort of slowly travels to the core. Because the axon's falling apart outside. Wait, did we go back one? Go back one? Yeah, we talked about all of them. Did we talk about Wallerian? Okay, so those are your different ways that a nerve fiber can fail. So either the insulin fails, something nutritionally deficient makes the axon start falling apart distally, kind of propagates up the cell body, or there's some sort of compression or cut or lesion that causes axon dysfunction. And so an electromyelogram can actually pick up these differences. And like when I order nerve conduction studies, I have an amazing PM&R person in my clinic who does the best studies I've ever seen. She can pick up anything. She'll be able to tell me that it's axon demyelination, or it's a motor neuropathy, or you have a conduction block here, or blah, blah, blah. So we have the tools to figure this stuff out. It's just somebody has to order it for you. So how do I treat nerve pain? First, I find out if it is nerve pain. So, a lot of times something that we think is nerve pain is not, and vice versa. I have a ton of people that come see me that think they have plantar fasciitis, but they actually have compression of a nerve. Once that is addressed, they get better. But if you keep addressing the connective tissue, they're not going to get better. So you have to do a good diagnostic, profile of somebody. And this is when I'll run a metabolic panel. I'll order a hormonal panel, an electrolyte panel. I'll check their vitamin levels. And I'll try to see if anything that I know affects a nerve is off. And then we address that core problem, like a B12 deficiency, D3 deficiency, what have you. So basically, if we find an underlying cause, we treat it. If you know someone's on chemotherapy, or like, let's say, like a Arimidex or one of these estrogen meds that people after breast cancer have to take, we know those cause joint and nerve pain, then it is what it is, and you just treat the symptoms. So sometimes the cause is treating a bigger problem and you're just kind of stuck with it and you have to manage it. That's often the case with chemotherapy. But if it's something simple like in a trapped nerve, like a carpal tunnel where the connective tissue here in the wrist is jammed up on the median nerve, well, you just split that connective tissue and give the nerve a little bit of freedom and it feels better. Physical therapy is awesome for nerve-related symptoms, but you have to have a physical therapist that understands how to treat nerve pain. So they have to understand the anatomy of the nerves. They have to understand the stretch that should be applied at any given joint, the length of time, how frequently, et cetera, the deep tissue massage that can go with it, massaging the fascial planes that follow the nerve. But physical therapy, if you have a good physical therapist and a good order from the doctor, you can actually treat a lot of nerve pain this way. Even diabetic, I've sent plenty of diabetics with peripheral neuropathy to physical therapy, and they feel better after it. And then obviously you have to control the inflammation around the nerve endings. PEA is amazing for that because it's specific to the mast cells that vomit out the excitatory neurotransmitters at peripheral nerves after an insult, compression, or injury. Next. Okay, So your sensory motor neuropathies, things like chemotherapy, diabetes, alcohol, you have to correct the underlying deficiency. One of the reasons alcohol causes problems is not just that it's a toxin in and of itself, but a lot of alcoholics fail to eat properly, and will end up with mineral deficiencies and vitamin deficiencies. So I remember when I was a resident, we used to always, whenever we had an alcoholic with an injury, to try to help them from going into what are called delirium tremors or DTs, where they shake and have all these horrible physical responses to the lack of alcohol. We actually used to hang something called a banana bag, which is now being sold as like, IV therapy all around. But the banana bag had thiamine and a couple other nutritional items that most alcoholics are missing. So you would just replace it with an IV bag as you were treating them. So you got to make sure the B vitamins are there, omega-3s, which help the myelin and help the cell membrane function properly. You have to control the hyperglycemia, or you just have this ongoing problem that's going to cause that dying back of the axon. So that peripheral damage to the axon that just starts growing closer and closer to the core. Topical pain relief, we've already talked about lidocaine and capsaicin, I think. I use a lot of natural things like menthol, peppermint. I have a bunch of natural pain creams we've come up with. Delta 8, believe it or not, is an amazing natural topical ointment that controls pain through what's called the endocannabinoid system, which regulates the firing threshold of these nerves. So if you can control that with natural things, it's always the best. And then obviously there's a lot of drugs for this. So gabapentin, Cymbalta, narcotics, Celebrex, Lyrica, tizanidine, and then carbamazepine. And then you start getting into even meds that we use for Parkinson's, we sometimes use for neuropathic type pain. So we talked about this already. Make sure that you have the hyperglycemia under control. I know it's easier said than done. Weight loss helps the most. It's the only way you can really kind of reverse this, or what? Oh, hyperglycemia means you have too much sugar in your blood, which triggers this whole release of insulin, which then causes a whole bunch of other problems. Weight loss helps a lot. So Ozempic is being used by a lot of people for weight loss. It's a GLP-1 inhibitor. It's one of the gut hormones. And that's basically, it makes people not want to eat, either through nausea or just making them feel full. That's been very effective. Not covered for everybody, of course. There's another one that Eli Lilly makes called Mounjaro. Similar thing. Bariatric surgery has been great to reverse a lot of these problems because of the forced weight loss. Converting to an anti-inflammatory diet, I cannot tell you how many times I've seen this work. The minute somebody stops eating red meat 3 or 4 times a week, the minute they stop eating sugar all the time, the minute they stop eating highly processed refined white bread and all of these kind of foods that you find at the grocery store, and just start eating stuff that actually grows on trees and in dirt and is like natural, it is amazing how much better people feel. Because most of what we eat in America is inducing the prostaglandins, the chronic inflammation, the oxidative stress that is making those action potentials fire more easily. You got to treat your sugar addiction. A lot of people don't want to talk about it, but sugar is very addictive. I think it's more addictive than cocaine. Somebody fact check me on that, but I'm pretty sure. Sugar is massively addictive, and it's hidden in everything. They put sugar in potato chips to make sure you want to keep eating the potato chips. Because most of us hit a salt threshold. There's a sensor in the brain that says you have enough salt. You don't need any more salt. Most people will stop eating salt when it's time to stop eating salt. But if there's hidden sugar in there, they don't. So you got to be very careful with these packaged foods you're getting, because they're basically designed to kill you, more or less, which is terrible. But that's the world we live in. And then you got to check your uric acid levels. So one thing a lot of people miss is a lot of people with diabetes and nerve pain and autoimmune, they also have higher uric acid levels because they're breaking down purines and their system's just not quite right. And uric acid in and of itself is extremely inflammatory. It'll allow crystallization near nerve endings, and that actually causes pain too. We already talked about physical therapy and how that works. What do you do if you're not going to give somebody Norco? Well, this is a group, a study where they looked at vitamin D versus placebo versus mindfulness and vitamin D. So this is a 28,000 international units of vitamin D per week for 12 weeks. Okay, so it's a 12-week study. They had 4 groups. One group of patients did mindfulness training with vitamin D supplements. One group took a placebo. One group did mindfulness training with a placebo. One group just did mindfulness training. And what they found was that all of these groups got better except for the placebo group. But the group that did the best was the one that supplemented with vitamin D and did mindfulness training. So remember what I told you, Dr. Melzak said pain is in the brain. So if you get the right mindset and you do, and I don't train people in mindfulness, I'll send them out for it. I try to do my own mindfulness and things like that. But you know how you hear about pro athletes doing biofeedback? That's kind of mindfulness training. But if you can get a good cognitive behavioral therapy or a mindfulness-based pain therapy program, there is a lot of pain you can modulate and control just with that. And then if you add vitamin D3, because there are D3 receptors on the nerves and on the neurons and all throughout the body that control inflammation. D is actually a hormone. It's not really a vitamin. It functions like a hormone. So D deficiency is a big problem that is a source of a lot of our issues in this country, one of which is chronic pain. So remember this, mindfulness-based training plus vitamin D, they did great for nerve-based chronic pain. And yes, it does work. So the biology of pain, like this talk I'm giving you right now, was explained to another group of 66 patients, and then they were trained in mindfulness to control stress, to sort of manage the normal stress we're always under in our daily lives. And then they were also offered standard medications. Pregabalin is Lyrica, duloxetine is Cymbalta, or a tricyclic antidepressant. 63% of the people in the mindfulness-based training group improved. Only 22% of the controls did. So they were all offered the same meds. Just one group was taught, this is what pain is, and this is how you can use mindfulness for it. And the other group was not taught that. So they were not allowed to know. They were not empowered. The empowered group did way better than the unempowered group. So that's why I do these talks on a Saturday morning, is I'm trying to give you guys the power to manage your own issues, because you can. There's so many things you can do without coming to see somebody like me. And then the people in the mindfulness-based stress reduction protocol had better function, less pain catastrophizing. So that's an actual thing. There's actually a test you can take to see if you're a pain catastrophizer. So these are the people you see that like roll their ankle and act like, they were just shot with an AK-47. Like, it's just the end of the world. Nothing can be done. Everything's over. Oh my God, it hurts so bad. I can't move. Like, it's just so catastrophic. There's actually a test to take. You can actually grade this and scale people. Some people catastrophize, some people don't. Some people are very stoic, some people are not. But you had less catastrophizing after mindfulness-based training. Less depression. Again, it's the same neurotransmitters, remember? So if you can control the central processing unit, you also can control the mood. Less perceived stress, and then QOL is quality of life. So a better quality of life. Now, what I will tell you, this list here, the exact opposite is true for chronic narcotic use, which begs the question, why is that covered at all? I don't know. Most people on long-term narcotics, less function, more pain, more catastrophizing, more depression, more perceived stress, worse quality of life. I think we all have somebody in our family or life that you can attribute that I am correct when I say that. Okay, so one thing that works well, one technique of mindfulness-based training is called progressive muscle relaxation. So there's a relaxation group, and then there's a meditation group in this study. Meditation, is breathing introspection, where you just notice what's going on in you. Sometimes there's a chant involved. Sometimes there's a repeated phrase. So they look in a control group. So 3 groups in this study: relaxation, progressive muscle relaxation, meditation, control, only 20 minutes a day for 12 weeks. And the pain scores were lower after 14 weeks in the relaxation and the mindfulness groups, but not the control group. And they also had better quality of life scores. Just from progressively saying, relax toe muscles, relax foot muscles. I mean, I'm simplifying this. There's ways to do this properly. Relax calf muscles. Just by sort of being within yourself and sensing yourself and sort of feeling that control, people felt better. They had less pain. Okay, and they've done functional MRI studies showing what's going on in the brain. They've done biomarker studies in serum, multiple animal studies, which are called preclinical studies, and we know that this stuff works. So the mechanism behind the success of mindfulness has to do with certain pathways in the brain where these electrical circuits from the peripheral receptors through the transmission line that go to the brain, how they are modified in the brain before you're allowed to say what you know, to have a perception. So the same areas, non-opioid pathways in the brain that handle pain were engaged with mindfulness. And they found that by doing MRI studies where certain areas would light up based on what was happening. This was a very distinct result from placebo. Remember, placebo is the most studied drug ever and the most successful drug ever. Placebos work amazingly well. Placebo is based on expectation, beliefs, and mindset. And they think that this mindfulness, where you actually control your own mind, works in a different pathway than placebo itself, but it works. And they've proved it. You can restructure the reward processing centers of your brain with neuroplasticity using mindfulness. That's like getting over your sugar addiction. You can do the same thing with managing and modulating how you respond to different painful stimuli. And then improved stress resilience happens with mindfulness too. So, you know, like normally if you get, let's say, an overdue bill in the mail, let's say you fly off the handle and you went crazy, that means you have no stress resilience. Well, you can improve your stress resilience and kind of get that overdue bill and then say, okay, well, how am I going to deal with this? As opposed to flying off the handle, just with mindfulness-based training. And actually, you can get better stress resilience from sitting in Finnish saunas, the hot saunas, and or with cold exposure, which we could talk about at some other talk. So these are the studies I'm talking about where they show different areas of the brain lighting up with pain, and then if you meditate. So you can actually control how your brain responds to the electrical current. Remember, it's just ions, it's just sodium, potassium, chloride. So you can control how the channels open and close based on mindfulness training. I mean, it's pretty miraculous. And it has to do with controlling cortisol levels and neuroplasticity. So you basically have less pain related to the afferent processing. Remember, afferent means signal from outside in. So you have less pain because you process that nociceptive, painful information differently. Wait, go back. And then, that just threw me off, sorry. And then also an improved mood helps. So you've probably noticed this, happier people, more positive people for any given insult or injury have less pain or seem to handle it better. Well, there's a reason for that. Positivity reduces pain ratings. They're showing this in study after study after study. And this is because the prefrontal cortex, your executive level part of the brain, controls things better in happier people and positive people. You have more ability to be an executive of yourself. Your prefrontal cortex works better, which modulates most of the signals from the hypothalamus and all the pain centers that are a little bit more primitive. So next slide. Okay. So how do these drugs work that we normally take for pain? We kind of talked about this a bit. You've got the selective serotonin reuptake inhibitors, the selective norepinephrine reuptake inhibitors, MAO inhibitors. You've got Cymbalta, which is a dual uptake inhibitor, meaning it affects norepinephrine and serotonin. So these kind of drugs change that neurotransmitter that, you know, hops synapse through that cleft. You've got NMDA receptor activity, which is one of the modulating things in the spinal cord and the brain that'll either amplify or depress a signal strength. Ketamine, dextromethorphan, methadone, all these drugs work that way. Then you've got descending inhibition. So you can change, you know, you've got ascending signals and descending signals. So all of these drugs here, tramadol, the opioids, they're all more centrally acting, and they just change how the brain perceives a signal and how it modifies it and how you perceive pain. Not because the signal's changed at all from where you were cut or wherever the tumor is. That's the same, but if you can mask it in the brain with an opioid, that's how those work. But unfortunately, they also have many other side effects, and then they don't work over time, as we discussed. All right. So how do local anesthetics, how does that lidocaine work for the postherpetic neuralgia? Well, lidocaine is one of the oldest things since time began, and they actually used to use cocaine for this purpose. So you used to be able to go to the drugstore and get cocaine toothache drops for your baby, or you could go get maltine with coca wine. And remember, Coca-Cola's original recipe had cocaine in it. How does it work? It works by blocking the voltage-gated sodium channel. So if you can block that channel from opening, guess what you never get? You never get that action potential, which means what? That C fiber never sends a pain signal to your brain. So this is how lidocaine works, marcaine, bupivacaine, cocaine, anything that ends in ane like that. They block the channel. Antidepressants, we already talked that. They were noted 30 years ago to be effective for treating pain. to be frank, we really don't know why. We think it's because you change the serotonin uptake. But then again, just this past year, a huge study was released that showed that depressed people don't have any difference in their serotonin levels than non-depressed people. So now we really don't know how they work. All we know is it's the same neurotransmitter. It seems to change the reuptake at that synaptic cleft. So they work, but we don't really know why. But I will tell you, they have a lot of side effects, from weight gain to bad dreams to suicidal tendencies. So you don't want to go into these lightly, and you want to monitor anybody that's on them. Anti-inflammatories. Well, if you've got nerve pain because there's inflammation in the area and the cytokines are inducing the threshold to drop and to trigger firing, why don't we just control the inflammation? And that's a valid way to treat pain. So anything from all of your prostaglandin depressors, which will be like steroids, Celebrex, ibuprofen, et cetera, to anything that reduces the white blood cells from releasing their inflammatory mediators, so palmitoyl ethanolamide, things like that. And again, omega-3s. If you can fill that cell membrane there with omega-3 fatty acids and have fewer omega-6, then you cannot go down what's called the arachidonic acid pathway, which is how prostaglandins are made. Omega-3 pushes you down what's called a resolvin pathway or a healing pathway, and you don't get the irritating, painful prostaglandins. So this is another reason I love omega-3s for people that have pain, and it's just really healthy for you in general. And then anticonvulsants. Okay, so why are we using anticonvulsants for pain? Well, honestly, because we do. It's totally off-label. Everybody does it. We do it all the time. I think it's allowed because it's cheap. It seems to work, but again, there's some side effects. People can take a ton of gabapentin, but the side effects tend to be brain fog, somnolence. Some people have crazy dreams. Some people get skin rash. I mean, side effects are all over the map, but generally the number one side effect is feeling sleepy. So if I order gabapentin for people, I usually just give them a low dose, and they should only take it at night. It's only FDA approved for post-herpetic neuralgia, as is lidocaine. So you probably, somebody out there that is listening to this has been prescribed gabapentin for nerve pain. It's just done all the time because we're allowed to practice medicine, whether or not something's on label or off label. We just have to use our best medical judgment. And gabapentin is a great drug for nerve pain. It just has side effects you got to be aware of. It's designed to be a GABA analog. Remember, GABA is that natural substance I told you about that's in the sleep gummy I have. But it actually doesn't affect the GABA receptors, which is weird. It was designed to do that, but it doesn't do that. But it does reduce that calcium influx. Remember I told you at that terminal bud, the calcium has to drop in for the neurotransmitters to go. Gabapentin will reduce that. And so it does depress the system. So how do we treat nerve pain in clinic? Well, this is a conundrum. This is why one of the reasons I started looking into natural remedies and other ways, because honestly, we don't do a good job of it. Only 50% of patients will get a 30% improvement with any given drug. So think about that. If there's two people and I give them both gabapentin, only one of them will even get a 30% improvement in pain. And that's considered okay by all of the regulatory bodies and the insurance companies. Well, if they don't get 40% or 50% improvement or 80% or 100, well, what do? Let's add another drug. And so we basically make cocktails for people. So you might have somebody that's on amitriptyline, bupropion, pregabalin, Celebrex, and Norco. I mean, this is very commonplace in medicine right now. I don't think it's the greatest thing we could do, but it's all we have right now, unless you're willing to go outside the box and think about these other things like natural substances, lifestyle changes, reducing blood glucose levels, exercise, getting your sleep under control, mindfulness. All of that works better than drugs, but I'm thinking that maybe it doesn't reimburse as well. I don't know. But you can see the drugs themselves aren't even that effective. So if you've been on any of these meds and it didn't really work that well for you, that's normal. Look, only half the people even get 1/3 improvement in their pain. It's kind of scary if you think about it. Right, next. So the natural ways. So this pictograph on the right is sort of the cascade of the problem with too much glucose in the blood, hyperglycemia, going to form advanced glycation end products, causing oxidative stress, reducing oxygen to the nerves. That's what nerve hypoxia is. So you'll get peripheral arterial disease like the atherosclerosis and the plaquing. Well, if a nerve doesn't get oxygen, it's not going to work right. Then you get inflammation, then you get brain inflammation and nerve inflammation, you get injury, so on, and you get pain. So what are the ways we can treat nerve pain? Well, if you are obese or overweight, the best thing you do is lose weight. Energy excess or too much glucose in your serum is not compatible with optimal living. Exercise helps a ton because it pulls glucose out of the bloodstream, reduces inflammation over time, and it does a whole bunch of repair and protein synthesis things that reduce pain. Proper sleep is probably the most important thing people can do for pain. Omega-3 fatty acids, we've talked about a bit. D3, we've talked about. Things like resveratrol or pterostilbene, which is from blueberries. These are extremely powerful plant-based antioxidants that reduce pain. I just read a great study where they actually combined resveratrol and Mobic for knee arthritis, and it worked wonderfully. Better than Mobic alone, better than placebo. So I love resveratrol. I take it for longevity, for brain health, and for the nootropic aspects of it. But I also take it because it's a very strong antioxidant. And I know with stress and the American diet and the pollution around me, I have constant attacks of oxidative stress. So I take resveratrol to fight that off, and it does treat pain. Alpha lipoic acid is a great antioxidant that goes into the fatty cell layers and also the more hydrophilic or water-loving cytosol. So it can actually function as an antioxidant on both sides. Also been shown to reduce pain. In fact, that's one of the frontline treatments or first-tier treatments in Europe for diabetic neuropathy is ALA. Chlorella is an algae that detoxes or chelates heavy metals. Remember I told you heavy metals are a toxin that can cause pain? Anything you can do to pull heavy metals out of your system, from sweating in a sauna to exercise to taking chlorella and other chelators, ALA too, helps. Turmeric is another great natural anti-inflammatory. I try to put all my patients with pain, be it nerve pain or arthritis pain, on baseline control of inflammation with natural products in the hopes that they will end up taking the synthetic drugs less often and at lower doses. And by and large, it's borne out and it works. So tart cherry extract, turmeric, palmitoyl ethanolamide, we talked about that. NMN is a precursor of what's called NAD, which is massively important to the bioenergetics of the cell. I don't know, way back in the earlier part of the talk, I told you about mitochondria needing to be productive to produce energy for that sodium pump to work, and obviously for other things to work in the nerve cell. If you don't have enough NAD, then you don't have enough ATP and nothing works right. And as we age, we get less and less NAD. So I take NMN every day just to get that up, just to optimally function. Glycemic control, can't stress it enough. This is where you have your metformins, your Ozempic, all these drugs that are meant to manage diabetes. Well, you can get it naturally through a substance called berberine, which is a type of a tree bark. It works just as well as metformin. That's been shown in multiple preclinical and clinical studies. And it's natural. And we have one in our product line. You can get over the counter. Just make sure it's, it is what it's supposed to be. And then, of course, mindfulness and meditation, the progressive muscle relaxation we talked about, the transcendental meditation. And then if you can get into a good cognitive behavioral or mindfulness-based pain therapy protocol. All of these are natural ways that in studies have worked as well or better than those other drugs I talked to you about. And these are way safer. And the side effect of all of this is better vascular health, better brain health, more longevity, better function, better GI system. Everything gets better if you can do these things naturally, if you can empower yourself. Next. And then peripheral nerve stimulator, somebody had a question about that. So again, based on the gate control theory of pain, the peripheral nerve stimulator, this diagram shows you there's a tiny little lead. I could hold it in my hand. It's like a thin filament. And I go down to the nerve that I've proven in my workup causes the pain. And I actually will lay it right next to that nerve, close the skin, that's it. You never even know it's there. And then you wear this little receiver with an adhesive patch that's no bigger than like a continuous glucose monitor or a matchbook. And it sends a wireless signal, which you can program. You'll program it to where it works and is most effective. And you can modulate and control your own pain because you're doing the gate control theory of pain. And you are changing the threshold that is needed to fire that painful signal just with this little device that is very safe, very effective. So the peripheral nerve stimulator we use for chronic limb pain or back pain, sometimes neck pain, but usually it's limb pain like elbow, wrist, knee, hip, ankle, foot, some of the nerves that come off the back like the cluneal nerves. You can actually put a peripheral nerve stimulator there, and then basically block the pain signal to the brain. So it's massively effective pain relief for the peripheral nerves, meaning anything that's not the brain or the spinal cord. Okay, so here's a European study about people's current satisfaction with their current treatment of their nerve pain. This is in Europe. They looked at almost 5,000 people, and in that survey study, 64% of the people found that the medications or the drugs they had been prescribed did not work. And about half of them just stopped taking the medications because they didn't work or it was annoying to take them. More importantly, about 14% of those stopped because of the side effects. On the right side here is a list of side effects of Tylenol. Paracetamol is its technical name and what it's called in Europe. Just look at this. Thrombocytopenia, meaning loss of white cells, blood and lymphatic system disorders, cardiac disorders, GI disorders, liver disorders, immune system disorders, skin disorders, metabolic disorders. That side effects list is pretty much absent from that natural treatment list I gave you before. And so it makes me, this is why I do what I do and why I've started doing all this research and gotten into this world of empowering people with natural or more natural ways to manage things. If only half the people even get 34% or 30% of pain relief, and all you're doing is adding more meds and escalating, what are we really doing for anybody? I don't think a lot. So I think there's a lot better ways to treat nerve-based pain, and I've kind of told you guys some of them. Okay, PEA we talked about a bit, palmitoyl ethanolamide, a natural fatty acid amide. It's in the same family of substances as is what CBD upregulates, anandamide and 2-AG. So it is one of the ligands or neurotransmitters in the endocannabinoid system. So this regulates the inflammation around peripheral nerve endings. PEA is strongly recommended for chronic neuropathic pain conditions like diabetic neuropathy, arachnoiditis, things like that. It's very natural. You make it yourself in your own body, just not making enough if you have neuropathic pain. Alpha lipoic acid, that too. Additionally, same as PEA, same as anything natural, you're never going to get that single molecule sudden change in how you feel like you do with synthetic drugs. Most of the synthetic drugs either turn on or off an enzyme, so you get a quicker effect. The ALA is an antioxidant. It has to be incorporated into each cell's antioxidant system, so it takes a number of weeks. I tell people to give natural medicine 2 to 3 months before they try to decide if it helped them or not. Basically, it helps the calcium channels function better and more appropriately, which remember is very important at that terminal bud at the synaptic cleft. And actually, they've studied ALA and it gives more pain relief than placebo. It's very, very safe. And if you combine it with CoQ10, it works even better for things like peripheral neuropathy, because CoQ10 is it's an antioxidant too, but it's mandatory for the electron transfer. So you cannot make ATP, that energy you need for that pump, without CoQ10. So the two together is very, very good for neuropathic pain. So those are just some of the natural things you can do that are much safer than the drugs we prescribe and have as good or better results. And the side effect is general health and good antioxidant status. So hopefully that gave you guys an understanding of what is a nerve, what is nerve pain, how does a nerve work, how do I control the pain, what are my tools? Okay, we have a question. ALA is alpha lipoic acid. It's just the chemical name of this phytochemical or chemical you make in your own body that is an antioxidant. All right, I think that's it. So if we don't have any other questions, our giveaway, is that our giveaway? We have to give away to the people that got data too. Okay. All right. The giveaway will be based on comments and questions, and we'll send those out this week. Any other questions? Otherwise, I'm sure everybody wants to get to their football game.
Just the people that asked about like fusions and back surgery and all of those.
So people ask that? Okay.
I mean, like one lady, she's limping, she's always X-rays. I just don't know how to do that without.
Oh, okay. So apparently there were a lot of questions from people that have had back surgery already, fusion surgery, and still have a lot of pain. Obviously, that requires a thorough clinical workup to try to figure out what can be done. Sadly, I see this all the time because what I've learned is people will go get their back surgery, they're immediately sent to pain management at their first post-op visit. And then the people that come see me are not happy with that because they don't want to be on narcotics and they don't want to keep getting jammed full of steroids. So they come to me to try to find an answer. But at that point, they've already had a spine fusion. And it's really tricky. Everyone's different. It's hard to treat that. But once you fuse those elements in the spine and motion changes like that, that is a project. I mean, I do it all the time. You would have to go see someone like me and get a thorough workup. It's not easy to answer that kind of question in this venue, obviously. Okay, we're going to read one question anyway.
All my MRIs, X-rays came back 99% normal. Doctor says shouldn't be making her feel. She says she's been limping for 8 months. She says she has arthritis in the hips and knees. She has inflammation, and both feet hurt and pinkies hurt. Burning, sharp pain under her feet, especially at night. Electrical shocks as well.
Okay.
MRI did not show neuropathy. Back feels heavy. Left arm is.
Okay, I got it.
You got it?
Sorry, that was a long question. Somebody's basically having a lot of arm and foot nerve-based pain, it sounds like, burning electrical kind of pain. Apparently, they went to see a physician who did an MRI of the back and said there was no neuropathy. Now, you cannot see neuropathy on an MRI. All you could potentially see is if there's a true compression of any given nerve. And just so you know this, even the MRI studies that show a nerve compression generally don't correlate with how people feel. So it's almost irrelevant what the MRI shows, sadly. I would, if I were this person and I was having what clearly sounds like nerve-based pain to me, maybe go get a second opinion. I would probably get a nerve conduction study, make sure it's technically done well with somebody that really knows what they're doing. And, you know, if you're in a direct access state with physical therapy, go see a physical therapist, because a lot of times they understand the human body anatomy better and how to treat you physically than most physicians do, even, I'm sorry to say. So they understand the nerve pathways and the fascial pathways better. And maybe just doing certain stretches or certain protocols of dry needling or cupping can loosen those nerves up enough to help you out. Sounds like you've got entrapment pain to me, but I would get a nerve conduction study if you were in my office. That'd be the first place I'd start. And those panels I talked about, looking at electrolytes, vitamins, metabolic health, your omega-3 to 6 ratio, things like that.
You have a lot of like thank yous, and then everybody's wanting to know, will it be saved?
Yeah, this talk will be saved and available on.
So I just said it'll be saved on your Facebook page. And
Facebook.
Also, I put the link for your seminars. They're on every website.
Oh, yeah, the links to my seminars are on the Well Theories website, which is my natural product line that I've come up with for this reason, because I just find what we do in medicine is woefully inadequate. And then the Healing Soul, which is the shoe I talked about, which is the first thing I did in this trip of empowerment. And then my private practice, which is Warner Orthopedics and Wellness. So there's links everywhere, but there is a Facebook page and you can find it. It will be saved, yes. Well, good. Well, I'm glad everybody spent some time doing this. Hopefully it helps you. I think it is important for us people to understand how our own bodies work. And hopefully that gave you some insight to how the nervous system really works and what can be done to make it better. And hopefully everybody has a great day.